Hello everyone, we are from SGD. Before we'll explain to you about our student project, Allergic Rhinitis. Next. So here we go, our members. Next. So the first one is background. For the background, allergic rhinitis is a very common disease that causes a symptomatic disorder of the nose because of IgE-mediated inflammation of the nasal tissue membrane after antigen or allergen exposure. There are many methods of diagnosing an allergic rhinitis, such as questionnaire that used as a screening tool developed by World Health Organization. Despite having a huge variety of methods to diagnose diseases, disease also has an increasing number of cases every year around the globe. Epidemically, allergic rhinitis affect almost a third of world population, and the number is still increasing every year. Unfortunately, the prevalent rate among adults in Indonesia is still unclear or unknown. Meanwhile, one study shown that 64.6% of allergic rhinitis patients who visited the Dr. Hasan Sadikin General Hospital Bandung, Indonesia, were between 10 until 21 years old, a relatively productive age number. The common symptom of allergic rhinitis often disturb quality of life, including the sleep pattern, which may vary cause exhaustion, drowsiness, emotional instability, and diminution of performance at the workplace. The allergic rhinitis patient also may develop other comorbidities, some of which including asthma, allergic conjunctivitis, and renal sinusitis. Next, for the problem statement, there are 9 key points of this review. Also, there is 9 points of aims, and also a benefit of this review. Next.
So the second chapter will be started with definition. Allergic rhinitis, or also known as pollinosis and hair fever, is an acute reaction of allergy to allergens, which usually harmless but able to cause allergic reaction to some people. Several most common allergens that usually cause allergic rhinitis are pollen, animal dander, and dust. Allergic rhinitis symptoms, which characterized by nasal congestion, sneezing, rhinorrhea, epiphora, acute sinusitis, and itching, occur after allergen was breathed in, ingested, injected, or contacted.
So next is about the epidemiology of allergic rhinitis. Basically, those who suffer from allergic rhinitis can be found worldwide. It is a disease that spreads throughout the world. There are 10 to 20% of the world population affected by this disease. Allergic rhinitis has affected a large number of population in Asia, as much as 27% in South Korea and 32% in Saudi Arabia. Meanwhile, in the USA, it is recorded that 20 to 40 million people are affected by this disease. 10 to 30% of the adult general population are sufferers of allergic rhinitis. As for children, the prevalence of this disease varies from 0.8 to 14.9% of sufferers aged 6 to 7 years and up to 39.7% of children aged 13 to 14 years. Therefore, it is considered as one of the most common chronic diseases in the world.
Okay, thank you for the opportunity. Next, now we are going to talk about the etiology. Rhinitis allergy is an IgE-mediated inflammation of the nasal mucosa due to exposure with the allergens such as pollen, dust mites, animal dander, and molds. Based on literature review, there are several risk factors that could cause rhinitis allergy, such as age, body mass index, age of gestation, breastfeeding, alcohol drinking, sleep time, smoking, stress level, traffic, family history, and family size. That's all. The next one is going to be explained by my colleague.
My name is Gede Nugradena, and I will explain the pathogenesis of rhinitis allergy. First, the patient will inhale some allergen. The allergen then causes IgE antibody to accumulate on nasal epithelium and bind to mast cell distributed over the nasal mucosa. In response to the antibody-antigen relation, chemical mediators such as histamine are released from mast cell. This chemical will irritate the sensory nerve and blood vessel of the nasal mucosa, causing sneeze, water rhinorrhea, and nasal blockage. Next, the inflammatory cells will infiltrate to the nasal mucosa, responding to chemical mediator and cytokines. Leukotrienes produced by the inflammatory cell will cause nasal mucosa swelling.
I explain about the classification. First, based on the duration, it divided into two. First, intermittent, so the symptoms that appears for less than 4 days in a week and it occurs for 4 consecutive weeks. Second, persistent, so the symptoms occurs for more than 4 days in a week and it lasts for 4 weeks. Next, based on the degree of severity. First, mild, so the criteria of mild are normal sleep, no impairment of daily activity, normal work or school, and no bothersome symptoms. Second, moderate to severe. The criteria are abnormal sleep, impairment of daily activity, problems at work or school, and bothersome symptoms. Next. So in recent years, there are 2 additional classifications. First is occupational, defined as persistent or intermittent symptoms that include hypersecretion, airflow limitation, pruritus, and sneezing. Second, local allergic rhinitis. It localized allergic response in the nasal mucosa in the absence of evidence of systemic atopy. This type of allergic rhinitis have negative skin tests in vitro tests for IgA, but can react to nasal challenges. The clinical manifestation of allergic rhinitis are sneezing, rhinorrhea, nasal obstruction, and nasal itching. Patient may also have allergic shiners, which occur because of infraorbital edema, nasal creasing as a result from nose rubbing to reduce the itching, and the Morgan lines, folds under the eyes, which are very common in patients with allergic rhinitis. Diagnosis can be made by clinical history, physical examination, detection of specific IgE, and finding potential allergens. There are three kinds of diagnostic tests. The first one is in vivo test, including skin prick test, nasal provocation test, and pollen challenge chambers. The second one is in vitro test, including allergen microarrays test, basophil, and mast cell activation test. The last one is cytological diagnosis, which uses nasal smear to detect any eosinophil. Thank you. So for the differential diagnosis, there are many other conditions present with the symptoms similar to allergic rhinitis, such as acute sinusitis. The most common cause of acute sinusitis is viruses such as rhinovirus, influenza virus, and virus. The most specific symptoms are purulent nasal drainage, accompanied by either nasal obstruction or facial pain. The next one is rhinitis medicamentosa. It is a drug-induced and non-allergic form of rhinitis. In RM, the excessive or improper use of nasal decongestants will induce the nasal mucosa. Next slide. The next one is cerebrospinal fluid rhinorrhea. Most of the cases of CSF rhinorrhea are the result of trauma. It is highly specific for CSF rhinorrhea when beta-2 transferrin present in nasal drainage. And the last one is atrophic rhinitis. It is characterized with a progressive atrophy of nasal mucosa and underlying bone that result in a nasal cavity that is widely patterned but full with copious full-smelling crust. The symptoms that may appear are severe nasal congestion, hyposmia, and a constant smell.
Okay, so the next one is management of rhinitis allergy. First is allergen avoidance. People with rhinitis allergy is advised to avoid contact with the relevant allergens and irritants. The second one is pharmacotherapy. It consists of anti-inflammatory therapies and medications for symptom relief, which are antihistamines, corticosteroids, leukotriene receptors antagonists or LTRAs, and sometimes decongestants. And the third one is allergen immunotherapy. It is used for patients whom pharmacotherapy and optimal allergen avoidance are insufficient to control the symptoms. Thank you. Next.
So hello, my name is Laras and my number is 103, so I will explain about complication. The first one is chronic rhinosinusitis. This is a nasal inflammation which presents with symptoms of nasal congestion or discharge. This characteristic is ongoing for more than 3 months, but it could be also become chronic rhinosinusitis with nasal polyps or nasal polyposis. That is the result of another chronic inflammation in the paranasal sinus mucosa, which present bilatory and typically benign. But this allergic rhinitis could be also risk factor for asthma. Next. So the next one is adenoid hypertrophy. This is resulted from the sensitization in allergic rhinosinusitis that can alter immunological parameters of the adenoid. And then the last one is persistent cough and eosinophilic esophagitis, but this is also need further research. And the next one is going to explain by my friend. Thank you.
Next, prevention of rhinitis allergy. Primary prevention that seems possible for rhinitis allergy in combination with asthma are avoiding smoking and tourism use in pregnancy, avoiding cold or fire with heating after birth, avoiding starting daycare between 18 until 36 months, avoiding sleeping on animal fur for infancy, and receiving vaccines. Ginger also can be used for prevention of IgE-mediated allergic disorders, including rhinitis allergy. Another potential immunosuppressive agent called 6-gingerol also contributes to suppress of cytokine-mediated immune responses. In children, the result of research before showed that long-term breastfeeding at least 12 months and a vaginal delivery are associated with a lower risk of developing childhood rhinitis allergy. And vaginal delivery has a significant protective effect for children who had been breastfed for longer compared to cesarean delivery.
Hi, my name is Duko Pratno and I will explain about the prognosis of rhinitis allergy. Rhinitis allergy mostly have good prognosis, depends on kind of treatments that patient receive like countermeasure, pharmacotherapy, and if it's necessary, immunotherapy. For countermeasure therapy like pollen-related allergen, it depends on the certain times like springs where the exposure of pollen increase. The condition of patients can get worse. For examples, the number of patients with rhinitis allergy because of cherry pollen increase when it's in cherry pollen seasons. The procedure to avoid the allergen like dust, pollens, and animal furs can increase the quality of life of patients. And for the pharmacotherapy, from prognosis to patients also have good prognosis on patients where patients have improvement on quality of life. Ability of medications like antihistamine, corticosteroids, and decongestant to reduce the symptoms make the patients can do daily tasks better than usual.
Okay, for the conclusion itself, for the first one, rhinitis allergy is an acute reaction
of allergy to allergen or allergens, and the risk factor itself could be seen on the screen, and also the prevalence too could be seen on screen. And the allergens, the allergens will enter the body and causing IgE to accumulate on nasal epithelium and bind to muscle and causes several allergy reaction. And next slide. Okay, the diagnosis. The diagnosis of allergic rhinitis could be made based by the patient clinical history and physical examination, detection of specific IgE, and finding the potential allergens. And for the differential diagnosis itself, it could be acute sinusitis, rhinitis medicamentosa, and etc. And the therapeutic itself could be done by allergens avoidance, nasal irrigation, and medication, especially for the symptoms, and allergy immunotherapy. And for the primary prevention could be by allergens avoidance, smoking avoidance, vaccine, daycare, sleeping time, and etc. Okay, next slide. And the prognosis for rhinitis allergy usually good and based on the therapy itself. And the suggestion, the researchers should do more research or review on the guideline in treating of each class of rhinitis allergy. Okay, so that's all for our presentation. Thank you.